Hello and welcome to this presentation on hyperhidrosis and iontophoresis. In this session, although I'm going to talk about iontophoresis in more detail, I'm going to give you a background on hyperhidrosis. I'm going to look at the epidemiology and pathogenesis of hyperhidrosis, the management options for patients with hyperhidrosis, because it's important that you're aware of other options that are available when patients ask you. Then concentrate on iontophoresis, how it works, how you get the patient ready for it, the records you need to keep, and the variables that affect iontophoresis, and some aspects of auditing it so you can prove that you're making a difference to your patients. I'll then run through setting up a ProPulse iontophoresis device so that you can see how it's done. My background is I haven't always done this job. Up until about 8 years ago, I was a dentist. I was a consultant oral maxillofacial surgeon in Manchester and latterly in private practice. But I left that and came to work for this company and I'm much happier since. The company that I work for are based in Hereford, in Herefordshire, home of the Hereford cattle and the SAS. And we make a product as a pharmaceutical company called Fibrovane, which is a sclerosant for treating varicose veins and spider veins of the legs. And we really got involved with hyperhidrosis because traditionally vascular surgeons were the surgeons who treated hyperhidrosis. So hyperhidrosis I would classify as a skin disorder rather than a skin disease because it's a normal physiological function, which is sweating, which we all do to control our temperature. But people with hyperhidrosis sweat greatly in excess of what's required to keep their temperature controlled. So they would sweat on a cold day. On a hot day, it's even worse, so they sweat very profusely. And as you can begin to imagine, it's not a very pleasant condition to have. It's estimated that about 1% of the population suffer with primary hyperhidrosis. That may be an underestimate. There are many more people who experience excessive sweating that wouldn't necessarily be classified medically as having hyperhidrosis, yet they would still benefit from many of the solutions that are available. So most patients that you see will have primary hyperhidrosis. That's also known as idiopathic because we don't know the cause of it, and sometimes known as focal because it affects certain focal areas of the body, especially the hands and feet and underarms, and sometimes also the face, especially in males. It presents symmetrically and bilaterally, so if one hand or one foot's affected, the other one will be similarly affected. It begins in childhood or adolescence. And that can differentiate it from other causes because if you get a patient who suddenly presents with excessive sweating in adulthood, then it's much less likely that it's primary hyperhidrosis and more likely to be secondary, which I'll talk about in a moment, which will probably have an underlying cause. Males and females are equally affected. And another characteristic of primary hyperhidrosis is it's not present when patients are asleep. So if a patient presents to you and says that yes, they're sweating and they wake up in the night and they're sweating excessively and all of the bedclothes are soaking wet, it's very unlikely it's going to be primary hyperhidrosis. There is a family history in many of these patients, and maybe as many as a third to a half will have a history of other members of the family being affected. It's known to be autosomal dominantly inherited, although a gene's not been identified as a precise cause, which means there's a 50-50 chance that an affected patient may pass it on to their offspring. And as I said, various incidences have been reported, but between 1% and 3% is considered a reasonable number, which means it's a lot of people affected in the population. Secondary hyperhidrosis is also known as generalized hyperhidrosis because it tends to affect people from head to toe. There are a few causes of focal secondary hyperhidrosis, and that's usually due to trauma of the cervical, of the sympathetic nervous chain, which sits down the back of the chest wall. So there are physiological causes of sweating, such as pregnancy, but especially the menopause. There are many drugs that can cause sweating as a side effect or an adverse effect of them, and there are hundreds of drugs that have this listed. Sometimes surgery to the cardiothoracic area where the sympathetic chain has been disturbed during the surgery can cause a very focal secondary hyperhidrosis. Infections, so we all know acute infections, viral infections, the flu, COVID can cause sweating as one of the effects of a viral infection. But sometimes there are infections where sweating can be one of the early manifestations of it. And a typical example of that is tuberculosis, the incidence of which was decreasing, but has steadily been increasing over the last 20 to 30 years. And sometimes, especially night sweats, can be a manifestation of TB. So patients presenting with night sweats should be thoroughly investigated for that possibility. There are endocrine disorders such as diabetes and hyperthyroidism. Some neoplasms, especially some types of lymphomas, can present with sweating. And then there are many immunologically mediated diseases such as rheumatoid arthritis, which can also cause sweating. Just imagine your day-to-day so far. If you woke up this morning and straight away your hands were wet as if you just washed them, your feet were wet as if you just stepped out of the shower, and how that would begin to affect your everyday activities. So things that we normally take for granted, using our hands for handling paper, using our phone, a computer, driving to work, walking across a tiled floor in our bare feet. All of these sorts of things would begin to have a significant effect on our day-to-day activities. So not surprisingly, ultimately, these things do have a significant effect on patients' well-being and their self-esteem, their ability to form interpersonal relationships with other people. It affects the type of leisure activities and social lives that they indulge in. It can affect the types of jobs that they choose. Some jobs are just not possible when your hands are wet all of the time. And ultimately, it can affect people's physical and mental health. It's a well-known fact that only about half the people with hyperhidrosis have ever consulted a healthcare professional. And so there are lots of people out there that try and manage it themselves. They're sometimes too scared to talk about it. Sometimes don't even realise that they've got a medical condition that there are solutions to help them with. There's not a great deal of research done on hyperhidrosis, but some that has been done in recent years has shown that multifocal hyperhidrosis is more common than we previously thought. And in a survey done in the United States, it was shown that majority of people had 3 or more sites affected, so hands, feet, and another area. So usually the underarms, especially for females, and sometimes the face for males. For most people, it stays the same or gets worse as they get older, which is contrary to what a lot of doctors will tell patients, especially when they take children to the GP with hyperhidrosis as youngsters. The doctors will often say they'll just grow out of it. Unfortunately, it's a lifelong condition, and patients with hyperhidrosis don't grow out of it. And for most people, it affects them whatever time of year, whether it's spring, summer, autumn, or winter. A survey done, another one done in the United States, showed a prevalence of about nearly 5%, but this probably included a lot of people who are in that borderline area with not having clinical hyperhidrosis, but still sweating excessively and therefore affecting their everyday lives. And this was the study that showed it had significant effects on patients' social life, their sense of well-being, their emotional health, and not surprisingly then their mental health, and ultimately their physical health. There is a score that can be used, a very useful tool that can be given to patients before treatment and after treatment, and you ask them on that particular day which of those 4 statements they most closely relate to, and it will give you a score of the severity of their hyperhidrosis from 1 to 4. So most patients will score 3 or 4 when they come to you initially, but you would hope after having had treatment, they would score themselves as 1 or 2. Now, the pathophysiology of hyperhidrosis is reasonably well understood, but there are some aspects that we still don't fully understand. We know that it's the eccrine glands as opposed to the apocrine glands that are affected. And we know that in patients with hyperhidrosis, there is a normal distribution of the eccrine glands within the skin. So normally there is a higher concentration in the hands, the feet, the face, the underarms. But in patients with hyperhidrosis, they don't have any more glands and they don't have any greater size glands. So they're not hypertrophic glands, but they're just switched on more than they need to be. So it's a hyperfunction of the eccrine glands. They have an increased basal sweat production, and then the normal stimuli that cause us to sweat will cause these patients to sweat profusely. We know that it's a sympathetic nervous activity that stimulates sweating, but unlike the rest of the sympathetic nervous system, which is controlled by adrenaline as a secondary neurotransmitter, the sweat glands are controlled by acetylcholine. Now that has implications if the doctors are choosing to treat patients with anticholinergic drugs, which will be very effective in stopping patients sweating. Unfortunately, though, they're not specific to the sweat glands, and it will also affect other parasympathetic activities such as salivation, gut motility, and bladder control. So they're not very well tolerated as a treatment. They can be used in short-term use, but for long-term use for most patients, they're just not very satisfactory. Now, we don't know whether this abnormal sympathetic activity arises centrally from within the brain or peripherally from the dorsal ganglia that sit in the back of the chest wall, but studies that have been done on patients with neurological conditions such as Parkinson's disease, where they've used deep brain stimulation, have shown that when you stimulate an area around the subthalamic nucleus, you can actually induce hyperhidrosis-like symptoms in patients. So it's currently thought that it's probably something centrally within the brain, around this area of the brain, that's just switched on more than needs to be and causes these patients to sweat excessively. Now, in terms of treatment, there's some general advice that you can give to patients. Many patients will have worked some of these things out themselves, so they tend to avoid tight-fitting clothing and man-made fabrics. So it would be better to choose cotton or woolen garments, which allow some air exchange with the skin. Patients will tend to wear black or white garments, so sweat marks won't show on the clothing. Wearing leather shoes is better than wearing man-made materials. Leather shoes allow some air exchange, but they also are able to absorb sweat very effectively. Some people will use barriers and absorbent materials, particularly in the underarm area, that just absorbs the sweat so it doesn't get shown on the outside of their clothing. Those are okay for short-term use, but if they wear sort of integrated clothing that has sweat protection, it's another layer of clothing and can sometimes cause issues with temperature control, especially as temperatures warm up. Good skin hygiene is important, so emollient washes rather than soap is just a normal good advice to patients. Many textbooks will also say identify trigger factors and modify behaviour, but the trigger factors for people to sweat are sort of everyday activities, entering a room of unfamiliar people, just going about your everyday tasks. If you advise patients to do that, they will often get more emotionally withdrawn, so it's not a good advice to give at all. If you suspect that a patient has secondary hyperhidrosis, then some very simple routine blood tests can exclude the majority of these causes. A chest X-ray is useful if you want to exclude tuberculosis, and if parasitic infection is suspected, then blood films can be useful. There are algorithms produced by the International Hyperhidrosis Society, which will enable you to work through treatments that patients have had already. If they've been unsuccessful, then it will advise you what would be the next best treatment to try. So those are freely available on the sweathelp.org website. Across most of the Western world, there is a hierarchy of treatment, beginning with antiperspirants, Moving on to iontophoresis. Cognitive behavioural therapy is often mentioned, especially in some of the NHS guidelines. That in itself is not going to help the patients, but it will help them in terms of managing their condition. And even just some informal cognitive behavioural therapy, giving patients hope when you see them, will be a great help to them. Botox is rarely practiced in the NHS these days, but it's available across a whole variety of private clinics. Miro-Dry is something that's available for the underarms, and I'll talk about all of these in more detail in a moment. There's various forms of local surgery, again, for underarms that are not really that effective. Anticholinergic drugs can be used in selective patients. And then the last resort treatment is sympathectomy, where the nerve is cut or deliberately damaged so that it can no longer transmit signals to the sweat glands. Starting with antiperspirants, they work best when they're applied at night time, because if you apply them in the morning when patients are about to sweat, then they get diluted and don't get a chance to exert their effect on the skin. Antiperspirants are often prescribed by GPs, such as Drychlor. They can be used on all parts of the body. They tend to be aluminium chloride or aluminium chloride hexahydrate based. They work by the metal ions in the antiperspirants, reacting with the sugars, the mucopolysaccharides produced in the sweat, which effectively causes a blockage of the sweat ducts leading from the gland, so the sweat can no longer reach the surface of the skin. Because they're very strong, they can cause skin irritation. So when these are used on the underarms or the face, because of their strength, they tend to be sort of about 20% solutions. They tend to be quite irritative to the skin, so they're not all that well tolerated. These strengths can be reasonably well tolerated on the skin of the hands and feet, because the skin is much thicker there and can tolerate those high strengths better. There is a concern that aluminium containing compounds are linked to Alzheimer's disease or breast cancer. Currently, there's no conclusive evidence that is the case, but who knows, that in the future that may be proven. We supply a range of products called Sweat Stop, which were developed by someone with hyperhidrosis. So there's a range of preparations and strengths of products that can be used basically from head to toe, and they're supplied by our Sweat Help website. The same company that makes Sweat Stop also make an aluminium-free product, which is classed as a medical device. It's only suitable for the underarms and only suitable for those with hyperhidrosis. It doesn't work well for people with normal levels of sweating, but it can be used quite effectively for those with hyperhidrosis. Moving then on to iontophoresis. Iontophoresis is a very old treatment and is essentially delivering ions across the skin using an electric current. It was first discovered when an anatomist, Shelley, was looking at the effects of electricity on the skin and noticed that it caused the sweat glands to stop working as effectively. We don't fully understand how it works, but it does rely on ions being in the tap water, so it doesn't work very well when water is soft. It's very effective for parts of the body that can be immersed in water, such as the hands, the feet, with adapted electrodes for the underarms and also for amputation stumps. The research gives figures of up to 92% success. Real world figures are a little bit lower than that, but for patients that can tolerate the sensation and can put in the time for treatment, it can be a very effective treatment for these areas. As I said before, it relies on ions in the tap water, so hard tap water is best. Amputees can have two issues. One is that if they were already suffering from hyperhidrosis in the first place, the nerves that used to supply the terminal part of their limb start to re-innervate the skin of the residual limb, the stump, and overstimulate the skin there. And secondly, amputees that wear prostheses, which are a cup that fits tightly over the residual limb, means that the sweat can't evaporate from the skin, and it tends to then start to cause problems like people have with their feet. So the skin is constantly hydrated, it gets macerated and ulcerated and prone to fungal infections. So adapted electrodes can be used successfully for these patients. Now you can buy iontophoresis devices online on eBay. This is one device that is being sold for around about £40. It's not a CE mark device. It is simply 2 baking trays, some kitchen sponge, some 9-volt batteries and some cables connected with crocodile clips. Whilst that may work, there's no way of controlling the current in a device like that. So do advise your patients not to pursue those sorts of devices. You can buy bona fide devices that have been CE marked, and we sell these available from our website, and ones that can be used by patients at home, and in the larger devices like the ProPulse, which tend to be used in hospital clinics. We don't fully understand how iontophoresis works. It's applying an electric current, it's driving ions into the skin. It's going to irritate the skin, and if you irritate the skin, then you tend to get a thickening of the skin, so the keratin layer starts to get thickened. We think that the duct gets irritated and so undergoes some metaplasia and narrows the diameter of the duct. You're driving ions into the salivary glands, into the sweat glands, which is going to alter the pH because you're driving hydrogen ions into there. It's probably a combination of these factors, and ultimately you do get a sort of physical plug formed in the duct leading from the gland, but it's a more lasting effect than antiperspirants. Now, the research studies that have been done on iontophoresis generally are on small cohorts of patients. They report very high levels of success because the patients will have received ideal amounts of current. They'll have been supervised during their treatment, and so as you would expect, the results are reasonably favourable. When I've tried to find some real-world figures, they're quite variable. Now, in Scotland, in Edinburgh, when they did an audit of their iontophoresis service, they showed a 43% success. Now, in Edinburgh, they tended to lend patients devices to use at home, and one aspect of that is that when patients start to treat themselves, they just don't turn up the current very high, so they're probably under-treating themselves. But also in Scotland, the water is very soft, and so there are 2 issues there that will affect the success. A survey that was published by McAleer in Dublin showed that they got about 80% success in hospital, but when they gave patients machines to use at home, the success was only just over 50%. And they found that patients were under-treating themselves, so they weren't turning up the current as high as they probably should have been to get the most use out of the device. Our local hospital here in Hereford gets around about 65% success overall, but they do treat a lot of axilla patients here. They get about 80% for hands and feet, which is about reasonable. So we would tend to say about 70 to 80% success is what you should expect. Some people just don't get success, one, because they can't tolerate the sensation in their skin. It's a sort of pins and needles sensations, which some people don't like. Some people describe it as it's feeling like insects crawling over the skin, so they just don't like that sensation, which is fair enough. Some people, however, just can't commit the time to do it. So you're looking at around about 20 minutes to treat the hands, 30 minutes to treat the feet, and if you're treating both sites, it's going to be an hour for most people, so they don't have the time to do it. We did a survey of people who'd bought iontophoresis devices from us, and we asked them what their hyperhidrosis severity score was before they started treatment and what it was after treatment. And not surprisingly, most were scoring 3 or 4 before they started the treatment. But after they'd had treatment, most fortunately were scoring 1 or 2. And that was with home use, but also with a lot of support from ourselves to ensure that they got the best results. There are not that many adverse events associated with iontophoresis. Most of them are very mild and they're preventable. Sometimes people can get some localized skin burns, particularly when we treat the axilla, if the electrodes haven't been positioned correctly. If any patients have any cuts or minor blemishes in the skin, then those should be covered with petroleum jelly before you start the treatment, because the electricity will find those cuts and they'll soon know about it if they're not being protected. Sometimes people get a line of erythema along the waterline where the current gets slightly concentrated. Any discomfort in the skin that occurs in between treatments can be treated with hydrocortisone cream just to dampen down the inflammation. Paradoxically, as some people move through the treatment sessions, they can complain that their skin starts to get dry and cracked. So good skin hygiene, using skin moisturizers to maintain the oily secretions in the skin is very helpful for those patients. There are a few real contraindications to iontophoresis. One of them is pregnancy, because we just don't do any elective treatment during pregnancy because we don't know the effects it could have on a developing fetus. If there are substantial metal implants in the line of the current, then those patients shouldn't be treated in that particular region. So, for example, if they've had orthopedic surgery to their legs or their hips, then you wouldn't treat the feet. It's a theoretical risk, but the risk is that if you pass an electric current through metal, it will heat up. And we know that bone necrosis occurs at a very low temperature, around 47 degrees, and osteonecrosis is not very pleasant. So we think the current traverses the skin rather than going deeper down into the tissues, but nevertheless, because we can't prove otherwise, we have a blanket ban on anyone who's had an implant that is in the line of the current. Cardiac pacemakers tend to be situated in the chest, usually on the left-hand side, just beneath the surface of the skin, and will be affected by electric currents running across the skin, so they're contraindicated. Epilepsy, the devices that we provide, the manufacturers don't contraindicate epilepsy, but only if it's well controlled. It's a similar sort of situation that you would ask yourself, is a patient well enough controlled to undergo an outpatient local anaesthetic surgical procedure? If that's the case, then iontophoresis is appropriate for them. If they're poorly controlled and they fit regularly in an uncontrolled manner, then you shouldn't be treating these patients, because it's more of a risk to them and to you for their treatment. The protocol for iontophoresis, you follow the instructions provided by the manufacturer. Any jewelry or body piercings that could be in the line of the current are removed, so rings and piercings, because they're metal and they will heat up and they could cause skin burns. You tend to use warm tap water just so that it's more pleasant for the patients to put their hands or feet into. You only need enough water to cover the affected areas. Now, the affected areas are the areas on the skin that are ridged with a fingerprinted area. So that's around about halfway up the depth of the hands or the feet. You then get the patients to place their hands or feet, and I'll show you this in a moment, into the water baths. You increase the current until they sense a tingling sensation, but it shouldn't be uncomfortable. Halfway through the treatment, you reverse the polarity. So that means the current will have run in one direction for half the treatment. So one hand or one foot will have get exposed to positive ions. When you reverse the polarity, the same hand or foot gets exposed then to negative ions. Always reduce the current down to 0 before you let the patients remove their hands or feet from the water baths. Because what these devices in essence are doing is applying a continuous current, which the device will measure according to the resistance it detects. So when the resistance increases, it increases the voltage to maintain the current. If you remove your hands suddenly, the resistance goes up quickly and the voltage will increase. So that will be responsible for the shocks that people receive. So the protocol that goes with the I2M devices is that you treat on days 1, 2, 4, 7, 10, etc. Now, it can be very difficult to comply with that sometimes. So the actual research that was done on these devices many years ago showed that you got the best success when you treated patients 3 times in week 1, twice in week 2, once in week 3 and once in week 4. So if you can gather some sort of pattern like that, then that will tend to give you the best initial success. Once patients have moved through this initial protocol, then they need maintenance treatment as necessary. I'll come on to the time and dose in a moment. You tend to use direct current for the hands and feet, but pulse current for the underarms and for children or any adults that have very sensitive skin. Remember, the current will flow across the shortest route, so we'll go up the legs, across the pelvis, down the other leg for the feet, across up the arm, across the chest, and down the other arm for the hands. When we surveyed our patients who bought devices, we asked them how often they retreated themselves once they'd gone through the initial protocol, and most patients retreated themselves once per week. Quite a few treated themselves twice a week, which may have been necessary or may have been just actually slightly over treating themselves, because once they find a treatment that works for them, they just don't want to risk getting sweaty again. However, some patients only needed to retreat themselves every few weeks or even every few months, so it is very variable between patients. For the underarms, you have special electrodes, which are sponge covered and have to be very closely adapted to the skin, and I'll show you that in a moment. So most hospital clinics have these carbon electrodes covered by sponges. There are ball-shaped electrodes which can be provided, but those are single patient use, so they tend not to be used very often in hospitals. I mentioned things that can affect iontophoresis, so the water hardness is one. So whether water is very soft, less than 60 parts per million of dissolved solids, then iontophoresis is less likely to be successful. We think that calcium is the most important ion in the water, and we know that devices that control the current rather than the voltage are more effective, because it's a measure of the current flow and therefore the number of ions driven into the skin, which determines the success of iontophoresis. Where the water is very soft, then you can add salts to the water, so adding bicarbonate of soda or even just simple table salt will improve the effectiveness. You can use bottled water from high mineral content areas, so mineral water from the southeastern half of the UK or from France or Italy tend to work very well. You can add glycopyrrolate, and the anticholinergic drug, to the water, which will make it very effective. I would tend to caution against that unless it's absolutely necessary, because if you start a patient on that drug in the hospital, when they're discharged, GPs will not want to prescribe it for the patient because it's very expensive. It's in the region of about £300 per gram. And so most GPs don't like to prescribe it because it's a big chunk out of their budget. Within the UK, the southeastern half from about Humberside down to Dorset, anything that's south and east of there, the water tends to be very hard. In the middle part of the country, it's moderately hard. As you move north and west in the UK, then the water starts to get a lot softer. Now, if you're going to take a drug, you would look at the prescribing instructions and check what dose you should take. And so it's a good idea to try and think about the dose when we think about iontophoresis. So the dose in iontophoresis is really the current level over the amount of time that's delivered. We think the ideal dose of current for the hands is around about 15 milliamps for 20 minutes. And for feet, it's anything up to 25 milliamps for 30 minutes. If you're using pulse current is only on for half the time, so you probably need to double the length of time if all your patient can tolerate is pulse current. There is, however, a lot of variation between patients. So I always say that you start with the level of current the patient is comfortable with. As they progress through that initial protocol of treatment, at each subsequent session, they should be able to tolerate slightly higher current at each session. So by the time you reach about halfway through, so say session 4 out of 7, the patient should be able to tolerate the maximum they can tolerate at that point. If they can only tolerate still at that particular point very low levels, say 5 or less than 10 milliamps, and they're not showing any signs of the treatment being effective at that point in time, then they can't tolerate a higher current dose, but what they would be able to tolerate is that current dose for a longer length of time. So think about extending the treatment time and seeing if that will improve the effectiveness of your treatment. If we think about that graphically, if they are on 20 milliamps for 20 minutes, they cross the threshold of effectiveness at 20-minute mark. If they're on a lower current, then it's going to take longer for them to cross that effective threshold. Having said all that, when we survey people who bought devices from ourselves, the median treatment times for that both the hands and feet were 20 minutes, and the treatment currents were 15 milliamps for the hands and feet, or 12.5 for the underarms. So we know that there is a lot of variation, but if you're finding that you're not getting effective treatment and the patient can tolerate only a very low dose of current, think about lengthening the treatment interval time. For record keeping, you need to have some indication that you've discussed the benefits and risks with the patient and given them informed consent. It's a good idea, especially in NHS clinics, that you do some form of pre-assessment, pre-treatment quality of life assessment. So the hyperhidrosis disease severity scale is very useful. Some clinics use the dermatology life quality index. At each treatment session, you record the date, review the treatment so far, report on any adverse events that may have occurred. Always record the current dose in terms of the milliamps and the duration of treatment. After you've completed the 7 treatments, we do some post-treatment quality of life assessment. So HDSS again, or the dermatology life quality index, and you should find that you've improved their quality of life having done the treatment for them. Moving on then to other treatments that are available. Botulinum toxin type A, informally known as Botox by many people. Botox is actually the preparatory name for the Allergan product, but people tend to call it, everyone calls it Botox, regardless of the manufacturer. That works by the release or blocking the release of acetylcholine at the nerve endings, therefore being unable to stimulate the sweat glands. It's only licensed for treating hyperhidrosis of the underarms, but there are practitioners around who will use it for treating the hands, the feet, the face, the parts of the torso. If a patient's going to go for that sort of treatment, it's important to make sure, or for the patient to make sure, that the practitioner has been appropriately trained in using Botox for hyperhidrosis and not just for aesthetics, because the method is quite different. It's very effective, but it tends to be quite short-lived and has to be repeated after about 4 to 6 months. Another treatment that's available privately for the underarms is Myradry. That uses a device that delivers a microwave treatment to all of the skin appendages, whilst at the same time cooling the surface of the skin. So it essentially fries all of the appendages in the dermal layer of the skin, so the eccrine glands, also the hair follicles, and any other structures that are in that region. It's shown to be very effective in the trials that have been done on it. It's a very expensive treatment, but it does appear to be the only permanent treatment at the moment that's available for the underarms. They have tried it for other parts of the body, but because the sensory nerves also sit in this region, it's not been used very successfully for the feet and the hands, because the damage to sensory nerves is a very real risk. I mentioned before anticholinergic drugs. One that's commonly prescribed is oxybutynin, as is propanthyline bromide. Glycopyrronium bromides are used in iontophoresis. These can be effective, but as I said, the unwanted effects are very real and do tend to limit their use for patients. Some people do find the slow release form of oxybutynin is better tolerated. There is, however, a number of large population-based studies that have been published that have shown a link between anticholinergic use and early onset dementia. So they're not to be used really for long term in most patients. Some patients will be given propranolol beta blockers where there is an element of anxiety. Anxiety with hyperhidrosis is a little bit of a catch-22. Patients get anxious about the prospect of sweating, but also anxiety is going to make anybody sweat anyway. So beta blockers can help some patients manage the condition more effectively. There's a number of surgical treatments for the underarms. Very few of these have any strong evidence to support their use. There are all sorts of treatments that have been tried, from just retrodermal curettage, liposuction, just to literally push under the skin and try and extract the sweat glands. Laser sweat ablation has been used. There's a procedure called Shelley's procedure, where you open up a large flap of skin in the underarm area and basically curette all of the sweat glands that you can see out of the skin and then stitch it back again. Most of these have quite high morbidity associated with them and are not really very effective that we think. The last resort treatment is sympathectomy, whereby you go in and literally ablate the sympathetic nerve, either by cutting it, clamping it, using radio frequency or laser on it, and that will be very effective in stopping the sweating of the affected area. However, it's quite a high risk because for the hands and feet and the face, it's done through the thorax. You have to deflate the lung to get access to the sympathetic chain. So pneumothorax is a very real risk afterwards. Most patients who've had this procedure undertaken develop compensatory sweating. So whilst they may no longer sweat in their underarms or their hands, the sweating tends to get transferred down the midline, which is much more difficult to manage. If it's done for the feet in the lumbar region, then sexual dysfunction is a very real and an unpleasant risk for patients. So it's really very much a last resort treatment. This is just a typical example of a patient who contacted us who'd had sympathetic surgery done. Whilst it reduced the sweating in his hands, every day when he goes about his everyday activities, his torso is absolutely soaked with sweat, and it's really made his life a misery. And that's not an uncommon tale at all. So patients who have that treatment need to be adequately informed of the risks so they can make an informed decision as to whether they go ahead with the treatment. Unfortunately, not very much research done, especially in the UK, on hyperhidrosis. A few years ago, I was involved with a hyperhidrosis priority setting partnership with the James Lind Alliance, where we published a paper highlighting the both patients and clinicians' priorities for research, and we hope that in time funding bodies will take that up and start to fund some research into this very debilitating condition. So those are the learning outcomes that I wanted to achieve in this session. I'll go through setting up the machine in a moment. If you want to have a certificate, if you email me to say that you've attended this session, I can provide you with a certificate, and that can be used in your records for your training. We have a number of leaflets available for patients, which if you contact me or contact the company, we can send out to you. We've got a leaflet for healthcare practitioners, which just outlines hyperhidrosis and the treatment options available. We run the Hyperhidrosis UK website, where there's lots of information for patients available, and patients can ask us questions about their condition and get advice on what to do. We sell products directly to patients through our Sweat Help website. And if you need to contact me, those are my contact details there. Now I'm just going to change the camera. I'll just end this presentation. And I'm going to change to the other camera and just go through setting up the device with you. Okay, so focusing on the device a little bit here. This is the Hyhperhidrosis ProPulse, and I'll run through the controls first, and then run through setting it up. Just move. You can make sure you hear me. The device needs to be charged up, and as it's charged up, plugging the charger into the side there. When it's on charge, it can't be used. That's just a protective mechanism, so it can't be used when it's plugged in to be charged. You switch on the device by using the on button. It runs through some self-testing, and the green light will indicate on the front panel there where it says battery. The green light means that it's charged up and it's okay to do treatment. The middle light there is an orange light, which means it's running out of charge, but there should be sufficient charge to complete one further treatment. And when the battery light's on red, it means it needs to be charged up. It's a good practice for the device anyway, to make sure that you charge it at least once a month, even if it's not being used. When you do switch the device on, it defaults to pulse current. That's that orange light in the middle there. Most of the time, you're going to want to switch that pulse light off so that you get direct current. Pulse current means that it's on for half the time and off for half the time. So make sure for most people, certainly for all adults, that you turn the pulse current off. When you've set the device up, and I'll run through setting it up in a moment, you use the up and down arrows on the generators there to increase the current by pressing repeatedly or holding the button down. The lights will start to light up on this indicator dial here as the current starts to flow. Now, the current's not going to flow at the moment because there's no circuit detected by the device. The milliamp light will show in the middle of that dial there when the current is flowing, and the timer will start to count up in minutes once the current started to flow. It's useful though to have another stopwatch device or kitchen timer that you can time the treatment as you're going along, especially when you're treating the hands and feet, which I'll show you in a moment. There are two generators in this device. The left-hand generator is supplied through cables plugged in the left side, and vice versa on the right-hand side there. So if I show you how to set up first of all, for the just treating the hands, you would take the cables, zoom out a bit here, take the set of red and black cables, and it doesn't really matter which generator you use, but we tend to say use the left-hand side generator if you're just treating one site. You plug the red and the black cables into the red and black there. Now that's actually not essential, but it's useful to make sure you set it up the same every time, so that especially when you're treating more than one part of the body, or you're working with a colleague, you know that you've all set the machine up exactly the same. You put one clip onto the corner of the electrode on one side and the other clip on the other side, like so. I always put red one side, black, so red first, black first. It doesn't matter if you do it the other way around, it doesn't matter at all. But do always make sure you set everything up the same every time. So you would then ask the patient to be sitting comfortably. Make sure they take any jewellery off that's on the line of the current. They remove rings off fingers. Anything that's above the head and neck is perfectly safe to leave. Anything that's on the torso, so belly button piercings, other piercings they might have, make sure they get removed. It's a good idea to have the patient sitting so they're comfortable and they can rest their arms on the table. Sometimes people will get a rolled up towel to put under their elbows just so it's a little bit more comfortable, because remember, the patient's going to be sitting here for around about 20 minutes. They should be just resting their hands lightly on the grills. You should make sure that the hand is on the plastic grill, that the grill's not been displaced and the hand could be making direct contact with the metal, because if that's the case, there'll be a concentration of current and you could get skin burns. So make sure the grills are placed over the electrodes and the hand is placed well within the confines of the grill. You would then pour enough water into the tray. Usually having a jug is helpful here. Warm water so that it goes about halfway up the depth of the skin of the hand. So once the patient's then comfortable with enough water in the tray, you can then come onto the device. You can use the up arrow there to increase the current until it's comfortable for the patient. When you first start, the patient will probably only tolerate less than 5 milliamps. That's fine, just as long as it's comfortable and it's not hurting them at all. You then progress through the treatment. For the hands, you would do 10 minutes. So time 10 minutes, either using the timer on the device or with a separate timer. When 10 minutes have been reached, you reduce the current right down to 0. You let the patients have a bit of a rest, so let them just shake their hands about, take their hands out of the water, replace their hands in the water, reverse the polarity on the device. So you change the polarity. So that means the current will have been flowing in one direction for half the session, and now it's going to flow in the other direction. Increase the current again until it's comfortable for the patient. It's often the case that once you reverse the polarity, the patients can tolerate either more or less than they could in the first polarity, and that's usually down to the whichever their dominant hand is, because the skin is slightly thicker or different on the dominant hand to the non-dominant hand. So don't worry if they could tolerate 5 milliamps in one way and 7 the other way, or vice versa. That's perfectly normal. Once you've reached a further 10 minutes of treatment, you reduce the polarity down to 0, the current down to 0, let them take their hands out. That's the treatment session completed. Now, if you're going to treat the hands and feet together, you set the device up as follows. So you take the other set of cables and you plug them into the other side of the device there. Red in red, black in black. Connect them up to the deeper foot trays. Again, putting the red on the same side and the black on the same side. And you'd obviously then put them onto the floor. Patient would put their feet into those and their hands into the trays that are on the table. Now, the feet need to have more current than the hands. So the best way that we found for this to be done, and I've tried this with a number of departments and quite a number of nurses, is the best way to do it is to start the feet off first. So the feet are going to need to have 30 minutes in total, hands 20 minutes in total. So if you start the feet off using the generator on the right hand side, so you increase the current until the patients can feel a tingling in their feet, time for 5 minutes. Now after 5 minutes, you then get the patients to place their hands in the trays, and you start with the left hand side generator doing the treatment for their hands. After a further 10 minutes has elapsed, which means the hands have had 10 minutes, but the feet have had 15 minutes in total, you reduce both of the generators down to 0, allow the patients just to have a rest for a second, reverse the polarity on both of the devices, on both of the generators, get the patient to replace their hands and feet into the water trays, increase the current up to a tolerable level, treat for a further 10 minutes. After a further 10 minutes, stop the hand treatment by reducing the current down to 0, but continue the feet current flow for a further 5 minutes. So that means the patient's had a further 15 minutes on the reversed polarity of treatment and 30 minutes of treatment for their feet in total, 20 minutes for their hands. That then should ensure that both sites get effectively treated. Once you finish with the device, obviously switch it off, take the clips off, fold up the cables. You want to dry off the electrodes and the grills. Grills take a bit more drying, so they need to be air dried, and people often stick them near a heat source or a radiator for them to dry. The electrodes can be wiped down and need to be dry before you put them away. For cleaning purposes, for cleaning the electrodes and the trays and the grills, your normal surface decontamination protocols will suffice. So Clinell wipes are what a lot of units will use, and they are sufficient. Once everything's dry, you can then pack it away for the next time of use. So that really concludes the training. Hopefully that's been useful for you. If you do have any questions, if there's anything that's unclear or you have any questions in the future, please don't hesitate to email me, because I will be able to answer most of those questions, I'm certain. Sometimes you get particular patients with particular conditions. People don't know whether you should do iontophoresis or how you should go about doing iontophoresis. So do feel free to contact me. I hope that's been useful for you. And as I said, don't hesitate to contact me if you've got any questions. Thank you very much for your time and attention. Bye for now.